This is the demonstration of a left-sided labyrinthectomy, transmastoid labyrinthectomy. Here we can see that we have begun doing a cortical mastoidectomy in this patient, and this patient happens to have a markedly sclerosed mastoid on the side on which labyrinthectomy is to be done. This is a patient of end-stage Meniere's disease with multiple episodes of refractory vertigo post sessions of gentamicin, and this is being done as a final definitive ablative procedure to correct the vertigo. Now, as you can see, the transmastoid labyrinthectomy needs us to have a wide exposure of the bony labyrinth to be able to commence the drilling of all three semicircular canals and the vestibule. But here in this situation, we can already see that the sigmoid sinus is far too anteposed. We can see the slight shadow of it, and the dura also is low-lying. Hence, it does not permit us to have the kind of exposure that we normally require to complete a full labyrinthectomy. Here we would need to decompress some bone around the dura and the sigmoid sinus after completely unroofing it to be able to achieve that space where we can drill the posterior and the superior semicircular canal comfortably and gain that posterior trajectory of vision inside the vestibule. As you see here, we are using right now a medium-sized burr under ample amount of irrigation, first defining the antrum and at the same time reducing or thinning the posterior canal wall. As you see, we cannot really do a small hole mastoidectomy and expect to be drilling the labyrinthectomy, because that's a far medium drilling as compared to what we normally do in a mastoid. So to be able to do that comfortably and avoid any complications such as bleeding, hemorrhage, or damage to the critical intracranial structures such as the sigmoid sinus and the middle fossa dura, we must have an adequate exposure. For that purpose, we would need to drill totally expose not only the sigmoid sinus but much more bone behind, inferior and superior to the sigmoid sinus, as well as the tegmen fossa dura, dural plate, and most importantly the sinodural angle. A good exposure of the sinodural angle, although is important in any patient in whom we plan to do a transmastoid labyrinthectomy or translabyrinthine approach towards the internal auditory canal, it becomes much more so important when the mastoid is relatively poorly pneumatized and sclerosed, because then every fraction millimeter of bone exposure that we achieve and we are able to get is fundamentally important to ensure the success of our main surgery, which is labyrinthectomy in this situation. We see here that the antrum is about to be opened. Superior lateral level, we can already see that the dura has achieved, where we have done some coagulation, and we really cannot be drilling much more above that on a medial aspect, but laterally we can drill more and expose some more dural plate. Here we are making the initial attempts to thin down the posterior canal wall, first superiorly, and then we would need to thin down it inferiorly so as to gain space between the posterior canal wall and the sigmoid sinus, which right now, because of the anteriorly positioned sinus, looks difficult. Ample amount of irrigation here is very important, because not only does it avoid excessive heat on the bone, it also allows us to keep operating and not get our suction cannulas blocked because of bone dust, nor compromise our vision. So the more the irrigation, the better is the field of vision, and the faster is the pace of surgery. You can see here that we initiate exposure of the bone in front of the sigmoid sinus as well as the sinodural angle, because this angle is very important for us to eventually achieve that posterior trajectory of vision inside the vestibule once we complete the drilling of all three semicircular canals. Leaving bone in this angle will not allow us the kind of exposure that we desire. One must keep in mind, this is an ablative surgery. This is not just merely partial drilling of one or two semicircular canals. all three semicircular canals have to be completely drilled down, and the vestibule has to be opened, along with removal of the membranous labyrinth in the vestibule, namely the sacral and the utricular end organs, so that this patient cannot have any further episodes of vertigo of the Meniere's that they normally have. Hence, an ablative procedure such as this cannot be done half-heartedly, where some bit of canals can be drilled and the rest can be left open because of lack of exposure. So exposure of the entire region has to be ensured before we even start drilling onto the canals. So we take more time here to expose the entire mastoid much more proficiently before we go down to drilling the canals. Here you are seeing that we are drilling onto the sigmoid sinus plate, all around it. Initially we did it superiorly, now we are gradually, progressively going inferiorly. As we go inferiorly, the burr size must be kept in mind. A very large sized burr will either damage the posterior canal wall, make a rent in it, which we do not desire, or has the potential to just make a hole in the sigmoid sinus, thus causing massive bleeding and frustratingly increasing our surgical time. So our goal here is to completely unroof the sigmoid sinus. We're not going to use any Bill's Island here because that is not enough to generate the kind of space that we desire, and we'll see that in time. So as you can see in this sclerosed mastoid, there are no cells here inferiorly. The tip is not pneumatized, and this thick block of bone has to be drilled cautiously and slowly with the right size burr to achieve the complete exposure of the sigmoid sinus from superior to inferior. And this is also important because the ampulated end of the posterior semicircular canal goes inferiorly medial to the vertical segment of facial nerve. So that part of the mastoid has to be exposed completely for us to be drilling the posterior ampulla very, very clearly. The process of sigmoid sinus unroofing is something that one must, it should be known to all otologists, because these situations can rise very often, whether it is a labyrinthectomy, whether it's a cochlear implant surgery in a markedly sclerosed mastoid. So in the same kind of way, we keep increasing the exposure anteriorly doing the persistent thinning of the posterior canal wall, creating this trough between the sigmoid sinus and the posterior canal wall, increasing exposure there, and at the same time increasing the exposure of the sinodural angle, and doing all these three things together one by one would eventually give us a good exposure. You can see how the shape of the sigmoid sinus now comes into picture, and how it being anteriorly positioned in this sclerosed mastoid is a good enough concern for us if we are to drill down the labyrinth completely. In a highly pneumatized mastoid, one may not require this exercise, and the sigmoid sinus can be left behind, and you may have enough amount of cellularity in the front to be able to still accomplish this exercise. So as we see here, the inferior portion of the sigmoid sinus is now coming into view slowly and steadily with the progressive drilling. The drilling can be done normally medial to lateral. The burr size here is the most important part, and ample irrigation as well. The burr also must not be kept stationary at one time, because then that has the potential to go through. The burr must be constantly moving, so that any possibility of exposure of the dura of the sinus, one must stop immediately. The posterior canal wall is still thick and needs to be thinned further, although making it paper thin should be avoided, because that in long term can lead to resorption of certain portion of the posterior canal wall, hence causing possibilities of eventual retractions. So anteriorly we're going to just expose and get a visualization of the short process of incus. We do not have to strictly expose the epitymplanum, but just for some additional light to get into our surgical field and to be able to see the lateral canal ampulla, one must turn slightly anteriorly to expose the posterior most part of the epitympanum, and one can stop where you start seeing the shadow of the short process of incus. Obviously, equal amount of bone must be drilled laterally as it is done medially, so that your drill and the suction get adequate amount of space to work inside without generating any conflict of instruments, as well as the water gets to drain, which is being used for constant irrigation. So the amount of bone that has to be drilled here inferiorly between the posterior canal wall and below the sigmoid sinus will depend on the amount of decompression that is so desired. The more the amount of decompression one desires of the sigmoid sinus for overall vision, the more the bone around the sinus, especially posteriorly and inferiorly, which has to be drilled. In this situation, we have just exposed some bone behind the sigmoid sinus, that is the retrosinus bone, as well as inferior to the sigmoid sinus, to be able to gather a posterior trajectory into the labyrinth. However, since we are not planning to go translabyrinthine into the internal auditory canal or to the posterior fossa dura, we can stop short here. If that were so, then we would have to decompress a lot more bone, expose the retrosinus dura as well, and that is when we would be able to achieve a maximal amount of sinus decompression. Here we can suit the amount of decompression required based on the exposure from time to time. If at a particular moment we feel that the exposure is inadequate and we still need to drill more bone posteriorly to the sinus, then we shall do so. Here, as you see now, we are doing more and more decompression of the sinodural angle. We are drilling the tegmen fossa dural plate using a large diamond burr anteriorly to posteriorly and also towards the sigmoid sinus, so that we are able to maximize this exposure of the sinodural angle. Now one can certainly appreciate the amount of restriction we have in the overall picture, though one can start seeing better because of the fact that we have drilled in front of the sigmoid sinus. But one has to understand that this is with regards to very superficial drilling, and if one was to clear cholesteatoma or some other disease or do a basic cortical mastoidectomy, this would have been sufficient. But since we are to go drill the entire labyrinthine block completely, then this exposure has to be rendered and considered inadequate and has to be substantially increased for us to achieve a good medial exposure. Now, large diamond burr is very, very safe to be used on the dural plate and the sigmoid sinus plate with a lot of ease. One has to just adjust the amount of pressure one puts. Some bit of slight beating over the sigmoid sinus dura is very common and can be managed generally using ample amount of irrigations and sometimes bipolar diathermy. We can see here that we have increased the amount of irrigation that we are using, and we do not intend to stop drilling, because then that wastes a substantial amount of time. We continue drilling, and some bit of ooze or bleeding can be managed in the profuse suction irrigation. We are now completely thinning the bone over the sigmoid sinus dura to the level of totally removing it. One can drill down the entire bone through this, or in the end thin it down to an eggshell thinness, which later can be removed using a broad septal raspberry. So now we resort to a Freer's or a broad septal elevator to remove the last thin eggshell bone over the sigmoid sinus, as seen here. And this step also again is done constantly under irrigation, because the slight amount of bleed, if one sees, can be washed away, and thus the vision is not compromised and we can proceed to the surgery. We strictly advise against the use of micro ear instruments or micro flap elevators for this step, because they are very fine and sharp and they can easily puncture the sigmoid sinus dura, thus causing hemorrhage. So it is best to resort to broad and blunt sort of elevators, the kind of ones we normally use in septoplasties or in the periosteal flap elevation in ear surgery. One has to make sure that you don't leave islands of bone behind, because then once you start decompressing this sinus, and if you press on those islands of bone, they themselves can cause puncture of the sigmoid sinus dura. So we are not, like I said, we are not using the Bills-Allen technique. We would be unroofing the entire sigmoid sinus dura for us to be able to then push it back and decompress it. We'll see in a short while how that's done. So we can see now how the sigmoid sinus has been completely unroofed right now. So it is just being unroofed, not really decompressed right now, but unroofing is the first step, and the amount of exposure we require till the levels of the posterior semicircular canals, that much length of the sigmoid sinus has to be unroofed. Once we have done that, we can see how much bone we may have to drill further by just gently pushing the sinus back using the same septal elevator. So we can see here how much bone in the anterior to the sigmoid sinus is there, which could later on be drilled once we have decompressed and pushed back the sinus slightly. So one can really notice that even 10 millimeters of excess bone exposure that we achieve by doing this step is extremely valuable while drilling the entire length of the posterior semicircular canal. Now we use bipolar moving strokes over the sigmoid sinus under constant irrigation, more the better, and this you see would start pushing back the sinus. This can be also used over the dura. Here in this situation we are not going to do it with dura because dura is okay for us, and we are just using it over the sigmoid sinus to both cause some hemostasis of the bleeding because of the surface vessels, as well as you can see how the entire sigmoid sinus starts to sit back without any pressure. Now as you can see here, there is a very superficial and a moving contact over the sigmoid sinus dura from the bipolar forceps on constant irrigation. At no point should pressure be exerted, because then the moment the bipolar forceps puncture the dura, we would have hemorrhage, and the whole exercise of decompressing it would be going waste, because then you would have to use Surgicel or some other hemostatic material to cover the sinus defect. Now one can see how much bone we have suddenly got clear for our drilling, and we would resume our large diamond burr to be used over this bone to achieve more exposure posteriorly. This step is not possible till we do not unroof the sigmoid sinus. So with this step, the most medial part of the sinodural angle is now being decompressed quite generously using the same diamond burr, because the field of vision has suddenly increased due to the posterior falling of the exposed sigmoid sinus. And we can see how we have suddenly gotten an increased space to drill in front of the sigmoid sinus between the posterior canal wall. As we see here, we are just in the perilabyrinthine cells here, more and more of the medial and the slightly lateral sinodural angle, and till this time we have not started drilling the semicircular canals, as we shall do that once we are totally secure and confident of our exposure laterally. So once again, with some more exposure of the bone anterior to the sinus, we are trying to just see if we can achieve another 1 to 2 millimeters of sinus decompression. And like I said initially, without further exposure of the posterior bone of the sigmoid sinus and the retrosinus dura, or the bone inferior to sigmoid sinus, this is the maximum amount of decompression we could achieve with this much bone exposure. And as of now, this appears to be just adequate to begin our definitive labyrinthectomy procedure. We are again now drilling some bone medial to the sigmoid sinus. This bone normally is the retrolabyrinthine bone, which covers the posterior fossa. Some more medial bone on the middle fossa dura needs to be also drilled with the same diamond burr to the level of just exposing the dura, not really damaging it, so that our exposure towards the superior canal, which sometimes is literally in contact with the middle fossa dural plate, must be made adequately. Now we can see how the sinodural angle is completely exposed from posterior to superior, and the dural plate has been literally thinned out, and the angle completely open. This is in contrast to how we began in the sclerosed mastoid, and goes on to show that the amount of exposure required laterally to commence medial drilling is very important. Now this gentle bipolar coagulation under ample amount of irrigation using thin light strokes basically just tightens the dural dura, whether it is tegmen, whether it is posterior fossa dura, and thus brings about a fair amount of decompression. We can see how much excess exposure we have achieved through this step. And now that we have seen that, we can initiate our drilling using a small, medium to small sized cutting burr over the labyrinth, because labyrinth is a hard block of bone. Using a diamond burr only would take us a long time to finish off the labyrinthectomy. So we begin with a small cutting burr, and as always we'll begin with the lateralmost canal, that is the lateral semicircular canal, followed by the posterior, and then later on by the superior semicircular canal. Now, though we have to drill in the direction of the respective canals, this is not a beautification sort of a surgery that we do in temporal bone drilling to first define all canals and then drill. This has to be done with a certain time constraints in mind. Hence, all three labyrinthine block bone would be drilled one by one together, and the exact canals or their domes would not be defined, as in contrast to a temporal bone drilling exercise. We can see here that I'm using a large bore suction cannula with an irrigation channel and with excess irrigation from another assistant. This is because this wide bore suction cannula also leads to dynamic decompression or compression of the posterior fossa dura, like in these pictures. Also, because of the size of the suction cannula, it is quite safe and secure, and it does not lead to any accidental penetration inside the sigmoid sinus, which is now exposed. So the lateral canal is now being drilled. And we can already see that part of it has already been opened. Now we are going to drill the bone behind it to define the level of the posterior canal. The posterior canal is located quite inferiorly. One must be keeping that in mind. And it's also on a more medial aspect. I had already mentioned that the posterior ampulla lies medial to the vertical segment of facial nerve. So a lot more bone has to be drilled to be able to define the posterior canal. And these are again, one going through the labyrinth, one has to understand this is the hardest bone in the body, and gentle strokes, even with a sharp cutting burr, are often not enough. And there has to be a requirement of a slight pressure exertion, which could be learned in the temporal bone exercises to be able to drill the labyrinthectomy. Not too much to create perforation and damage, but a feather-light drilling does not work on the labyrinth. It needs a certain amount of pressure, although with the drill constantly moving, to be able to make sure that the labyrinthectomy proceeds at its fair speed. You can see here that the lateral canal has been just partially opened, and we are now in the process of defining the posterior canal before we can go up towards the superior canal. Also very important is a continuous ample amount of irrigation from the assistants, so be able to get the bone dust out of the surgical field and not affect your surgical field exposure. The ampulla of the posterior canal is actually quite anterior towards the vertical segment of facial nerve. So one has to drill that area, but it has to be constantly borne in mind that since the vertical segment of facial nerve is lateral to the posterior ampulla, the facial nerve does represent a potential complication while doing this surgery, and that has to be always kept in mind. Even the slightest amount of exposure to the nerve sheath, one has to then stop and make that as the limit of anterior and inferior drilling. You can see now that the posterior canal also has been just partially opened here. So now one has in mind the partially open the lateral canal, the slightly and partially opened posterior canal. So we go on to expose some more bone behind these to be able to expose the common truss, from where we could initiate drilling towards the superior canal. You see here how the posterior canal is now completely open. I mean the dome of the canal, not the ampulla and the non-ampullated ends. And with the posterior canal now open, this one with the elevator points, you can see how closely it is hugging the sigmoid sinus. And if not for the sinus decompression, this step would be literally impossible, because you would not be able to drill that bone over the posterior canal. So to be able to expose the posterior canal, enough amount of exposure posteriorly is very important, and if the sigmoid sinus has to be unroofed in that process, then so be it. It is done because it is compulsory and it is not optional. further drill the lateral canal like so, and now one can see the entire shape of lateral canal. We can start seeing the non-ampullated end inferiorly. The ampullated end lies superiorly. And now we are going towards, if you just see carefully, we have opened the subarcuate vessel which is intimately associated with the superior canal. That often leads to some bleeding whenever we are drilling the superior canal in any translabyrinthine procedure. This is not a difficult vessel. This will keep bleeding till we open the superior canal, and this can be dealt with either using a diamond burr or a bipolar diathermy. Here we'll be using a fine skull base bipolar diathermy to coagulate the subarcuate vessel. And this step would be required more number of times. We can now see that the superior canal portion has also been opened. We can see here how the posterior canal, the lateral canal, and the superior canal, all three have been opened partially, though not completely, right now. Our limits of drilling, our superior limits of drilling in this procedure of transmastoid labyrinthectomy is the superior canal ampulla. We do not want to be crossing the superior canal ampulla anteriorly or superiorly, because if we go superior or anterior towards the superior canal ampulla and we drill medial, then we risk causing damage to the labyrinthine segment of facial nerve, which lies immediately underneath the ampulla of the superior semicircular canal. The labyrinthine segment of facial nerve also happens to be the most fragile and the thin segment of the facial nerve, and is particularly amenable to injury. So the boundary of our drilling in this patient, in this sort of situation, has to be completely respected. We cannot go anterior to the posterior ampulla, and we cannot go superior or anterior to the superior ampulla, because in both these situations, the vertical and the labyrinthine segments of facial nerve respectively are structures to be respected. We continue with our drilling to open all three canals. We have still not opened the vestibule, which lies anterior to the all three semicircular canals. No, with respect to our drilling, now one can easily understand how important it is to generously decompress the sinodural angle and the posterior fossa bone plate, because then, if not for that, then this kind of exposure of the labyrinth is virtually not possible, much more so in a limitedly pneumatized or a sclerosed mastoid. So as we drill towards the superior canal more, we see our subarcuate vessel still bothering us just a little, and like I said before, it has to be coagulated from time to time. Like I said, we have to definitely identify for sure the posterior canal ampulla, because that's our inferior limit of drilling. The surgery would not be over till we do so, because once we do that is only when we can expose the vestibule completely. One can again use the same fine bipolar or skull-based bipolars to coagulate the subarcuate vessel. Otherwise, one can also use some bone wax in this situation. Now we have shifted to a medium-sized diamond burr to completely drill out and clog all the opened ends of the semicircular canals. The three ampullas the non-ampullated end of the lateral canal and the crus commune, which is formed by the non-ampullated ends of the posterior and superior semicircular canal. So as it's seen here now, the vestibule has just been starting to be getting open, as all the three canals have been nearly drilled. And we can see how every fraction of millimeter of space that we have managed to get the exposure of is being now drilled completely, thus emphasizing the importance of a very reasonable and generous lateral exposure before we can commence this kind of medial drilling of the labyrinth. So we are not to, as mentioned, we are not to transgress the superior ampulla anteriorly and superiorly to safeguard our labyrinthine segment of facial nerve. And posteriorly, we can remove as much bone as possible towards the dura and towards the sigmoid sinus. And we can see that now the crus commune has just been opened with this drilling. And now one can also see how, when we are drilling, our suction irrigator, which is relatively broad-based, is dynamically sort of slightly compressing the sigmoid sinus behind as we drill more. Any thin suction used here is not all right for this step, because it leads to a potential risk towards the sigmoid sinus. We shift to a smaller cutting burr to drill out all the canals, the crus commune, which we had previously exposed. And now, since we had to further expose the posterior ampulla, we had to reduce the size of our burr, because the larger size burr would inadvertently start to cause damage towards the posterior, towards the vertical facial nerve, because it lies lateral to our posterior ampulla. So we can see here how now the vestibule is being opened slowly and steadily. The labyrinthine block is all but apart from the posterior ampulla, completely open and drilled. Our goal being to completely drill out the semicircular canals and open the vestibule, and to completely remove the sensory neuroepithelium from the vestibule. Now gentle strokes here are required, because we are trying to open up into the posterior ampulla, which is medial to the vertical facial nerve. And if we use an incorrect size of burr here, or we are too aggressive, then we could strike on the undersurface of the facial nerve, both here on the vertical segment as well as the undersurface of the facial nerve in the tympanic segment, or the second genu, which is immediately lateral to the vestibule. The vestibule sits medial to the second genu, and any drilling onto the vestibule as well has a potential adverse effect on the undersurface of facial nerve. You can see here now the labyrinth is open. The vestibule is now open. All the canals being drilled. But still we are unable to get a very good trajectory of vision inside the vestibule. The sensory neuroepithelium can now be seen inside the superior vestibule. From the vestibule, one can see the shadow of the vestibular aqueduct or the endolymphatic duct, which is the bony duct carrying the vestibular aqueduct, which comes posteriorly towards the posterior fossa dura and then takes a bend inferiorly. The endolymphatic sac too has been opened with the drill. We can just see the double shadow of it. This is the endolymphatic sac that has been drilled open, which is also another standalone procedure for Meniere's, that is side decompression. This is the endolymphatic sac that has been opened, the whitish shadow of a double dural layer that you can see. The vestibule now seems completely open. The vestibular duct has been opened. The endolymphatic duct has been probably drilled. The endolymphatic sac is now open. We are just using another diamond burr here to see if any other part of the canal is still left for us to be drilled before we can commence the removal of this sensory neuroepithelium from the vestibule. So the medial part of the temporal bone, the labyrinthine block of bone, the posterior semicircular canals and the vestibule have now been literally drilled to the limits of our lateral exposure, which are the tegmen superiorly and the sigmoid sinus posteriorly. One can also appreciate the amount of medial drilling that has been done and how our vision has gone quite deep. This is a lot of medial drilling, which normally in a broad otology setup is hardly ever done. So a small amount of bone over the lateral lip of the vestibule is now being drilled for us to be able to get a look inside the vestibule from posteriorly. This is the same step that I was cautioning against in the form that one has to be careful in this step. It has to be done with a lot of irrigation so that and with the drill constantly moving so that we do not touch or contact the second genu facial nerve fibers. This is the erstwhile endolymphatic duct or the vestibular aqueduct, which you can see coming posteriorly from the vestibule towards the posterior fossa very, very clearly. This is the vestibule now, the inferior most aspect of the vestibule. This is the superior aspect of the vestibule. We are clearing some of the epithelium using a bent pick or a needle. Here we would need to just probably tilt the patient slightly anteriorly for us to be able to achieve a posterior vision, and the suction also has been changed into a skull-base suction, which is tapered towards the end and has an olive tip. So we can just use any kind of an instrument, maybe a sharp sickle knife or a right-angled pick to clear the sensory neuroepithelium from the vestibule, which is now seen very, very clearly. Again, the caution being that this sharp instrument, whether it is a right-angle pick or a sickle knife, must not be used on the against the lateral lip of the vestibule, because then there could be a slight contact or trauma to the facial nerve fibers. So we would strictly use it on the medial bone of the vestibule to scrape it nicely and gently, but not towards the lateral, not on the undersurface of the lateral lip of the vestibule. because that is the intimate relationship of the facial nerve. This is the utricular and the saccular epithelium. The utricular epithelium normally lies more posteriorly and inferiorly, which is the banana-shaped vestibular end organ, and the saccular end organ is the more spherical shape, lying more anteriorly. That is also the premise of doing the staphyrotomy towards the posterior portion of the foot plate and not the anterior, so as to avoid damaging the saccule. Now we can resort to a very fine suction tip as well, which can go slightly inside the vestibule. You can see here how it is important to meticulously clean the entire vestibular epithelium, the neuroepithelium, which is the site of origin of the attacks of Meniere's disease. Here we are using a medium to small sized diamond burr to gently increase our exposure inside the vestibule by drilling the lateral lip of the vestibule. This is of course done with a feather touch under constant irrigation with the drill in motion, so that we do not contact the facial nerve fibers. The small burr can be gently taken inside the vestibule as well to drill the bone and to clear any epithelium if that has been left from our angled picks or needles. So this is again the vestibular aqueduct. You can see a fine shadow against the glare of the microscope going perpendicularly from the vestibule towards the posterior fossa. And the most of the epithelium from the vestibule has also been cleared. So we could use a cotton ball as well, or use the same right angle pick to scrape out all the neuroepithelium. And once done, that finishes our labyrinthectomy procedure. We could use a small size diamond here, probably 1.5 or 2 millimeters diamond, to just drill lightly onto the medial wall of vestibule, taking a lot of care so that the edge of the burr does not traumatize the undersurface of the tympanic genu or the second genu of the facial nerve. This is just done inside the vestibule slightly to be able to totally clear the vestibule from its end neuroepithelium. And this concludes our transmastoid labyrinthectomy procedure.